Yeah, we are scheduled.
Well, good morning. I'd like to introduce you all to the last pancreas session of the conference. This will be oral presentations 10. And just for housekeeping, all presentations will be 8 minutes with 2 minutes for the invited discussant and 2 minutes for question and answer. I'm Saba Ganai from University of North Dakota.
I'm Giuseppe Malleo from University of Verona, Italy.
And I'm Wesley Francis from Princess Margaret Hospital in Nassau, Bahamas.
All right, so we start for the first paper. Is Dr. Manzella here? Perfect. So how did COVID-19 influence use of neoadjuvant therapy before surgery for patients with HPV cancers? Let's hear the answer.
Is this on now? Yeah, okay. All right, my name's Alex. I'm a general surgery resident at Rutgers, and anyone that was in one of the oral sessions yesterday, the first half of this is gonna look very similar because it's part of an overall project looking at a number of different factors of operations that occurred during COVID. This is our wonderful surgical oncology team. Everyone here has been helping with the overall project and specifically with this component with the NAT and HPV. No financial disclosures or conflicts of interest. So as everyone's well aware, COVID significantly disrupted the US healthcare system, including elective operations and systemic therapy regimens starting in March 2020. In our state, in New Jersey, the government actually passed legislature that shut down all elective operations by law. And as those restrictions were eased, surgical and medical organizations also were publishing guidelines that determined what patients could go to the OR, what cases were more or less considered priority on a case-by-case basis in order to preserve hospital resources and to decrease excess risk to patients. Obviously, with cancer patients' risk for progression, immunocompromising medications, and overall immunocompromised state are all factors that were taken into account. And as a result, one of the possible moves for patients that were either unwilling to go to the OR or unable to get the opportunity to go to the OR could have been an increase in neoadjuvant therapy for select patients. So the aim of this project was to determine if the disruption of the US healthcare system led to an increased use of neoadjuvant therapy for pancreatic and hepatic malignancies. So we use the Vizient clinical database to look at this question. It gets national data from over 97% of academic medical centers across the country and over 100 oncologic hospitals. So we looked for inpatient pancreatic and hepatic operations using ICD-10 codes for diagnosis and procedure. So it'd be patients with pancreatic malignancy and a history of neoadjuvant therapy that underwent a pancreatic operation. And then for hepatic operations, there was both primary hepatic and secondary hepatic, which was colorectal mets, both with history of neoadjuvant therapy, then undergoing an operation. We broke it up into 2 time periods, a pre-pandemic period from March 2019 to February 2020, and then a pandemic time period from March 2020 to June 2022. For analysis, we use the control chart system as well as students' t-test and Wilcoxon rank sum. The students' t-test and Wilcoxon rank sum were just to compare the operative mean for the pre-pandemic and pandemic period to see if the baseline number of operations changed, whereas the control chart software was used to determine if there were changes in trends over time that were more transient. We have an example of a control chart on the right here. You see time plotted on the x-axis and number of events on the y-axis. Data points are plotted in blue. The software then calculates the distribution and the mean is plotted across the middle as the CL, which is the center line. And then it calculates a UCL and an LCL, which are the red horizontal lines at the top and the bottom, which are the upper and lower control limits. These are analogous to standard deviations, and the software uses them to determine whether or not changes over time are considered statistically significant. You can see in the first circle, there are 2 red diamonds. This is how it labels significant changes. The 2 ways that it can determine that the data points are significantly deviated is one, is in this instance, if they're very far from the mean, and that could only be 1 or 2 points in order to be considered significant. Or in the second circle, the second option would be if you have multiple points that aren't as far away from the mean, but are still clustering and trending in one direction, they can be considered significant. So we had 7,500 patients over 40 months. 74% were pancreatic malignancy undergoing pancreatic operation with a history of neoadjuvant therapy. 9% were hepatic operations for primary hepatic malignancies with a history of neoadjuvant therapy, and 17% were hepatic operations for colorectal metastases with a history of neoadjuvant therapy. So this data is our pancreas operative data. On the x-axis, we have time in months starting in March 2019, going to June 2022. We have a red vertical line at March 2020 that separates the pre-pandemic and pandemic time periods. And on the y-axis, we have the national number of monthly operative cases. And you can see there's a clear linear trend going from left to right. It looks like it's increasing over time. And so the software picks up on this, and it denotes two periods of statistical significance. The first, in the pre-pandemic period, it's labeling as low. And so these are 6 months where it's saying these cases are below the mean for the total period. Then there's a period in the middle that it establishes as the mean for the time period. And then as time goes on, it labels the cases at the end as statistically increased. So overall showing a trend of increasing operative intervention for patients with neoadjuvant therapy over time. And this is confirmed by the p-value less than 0.05, shows that the overall mean number of cases in the pre-pandemic and the pandemic period are significantly different. Contrast to this, we have this data, which is our primary hepatic malignancies undergoing hepatic operations. And in this instance, we don't see any red diamonds. And so the software does not denote any deviations that are considered statistically significant. And when you look at the way the data clusters around the center line, it's a relatively consistent trend. And this is confirmed by the non-significant p-value, showing that the mean is not significantly different. And finally, we have our secondary hepatic malignancies, specifically colorectal mets. And in this instance, we see late in the pandemic, there are about 3 months of statistically significantly increased operative intervention for patients that had a history of neoadjuvant therapy. But it's only for 3 months, and it drops back off. And further studies will have to be performed to extend the data outwards to see if this is truly a transient effect or if we're starting to see the beginning of a rise in operative volume there. With any database work, there's the general limitations of using a database, but there are 3 specific limitations to the Vizient database for this project that also will lead to further studies. The first is that for inpatient operations, Vizient uses ICD-10 procedure codes instead of CPT codes, which everyone, I believe, is more familiar with as what happens in the operating room and how it's defined. There's not a clear translation for CPT codes to ICD-10 codes, so we established a list of codes by using our own EMR to verify that these were correct, but there's obviously the potential for missed cases. Second, there's a lack of detailed oncologic data because Vizient is more of a quality improvement and administrative database. So further studies can look at other interventions, including neoadjuvant therapy, neoadjuvant procedures, and different regimens, duration of regimens, staging data, all of which that we have limited access to in Vizient. And finally, we have limited outcomes data. We can pick up general mortality and some general complications data, but nothing that's nearly as specific as what we could get out of perhaps like NCDB. So between these 3, we have plans for further studies that will delve into more of the granularity of the overall trends that we see here. So overall, we saw that pancreatic operations for patients with pancreatic malignancy that were treated with neoadjuvant therapy continued to increase during the pandemic, which matches a historic trend of increasing use of neoadjuvant therapy, especially for borderline or locally advanced pancreatic malignancies. We saw that hepatic operations for primary malignancies that were treated with neoadjuvant therapy were unaffected by the pandemic. And we saw that there was a small transient increase in the number of hepatic operations for secondary hepatic malignancies, specifically colorectal mets. But this returned to baseline in our data, and we'll need further study to track outwards to see if this is transient or not. So overall, we saw that the pandemic did not affect the pre-existing trends in the use of neoadjuvant therapy for operative candidates for pancreatic and hepatic malignancies. And I'll take any questions. Thank you.
Thank you very much. So the discussion, Dr. Ejaz from the Ohio State University.
Thank you. Congratulations on your presentation and a very interesting study. A couple comments and questions. So these findings are interesting in the overall increasing utilization of neoadjuvant therapy, particularly for pancreas cancer, but in the setting of the pandemic. You mentioned in the introduction that elective cases were restricted. Do you consider these cases to be elective, and how are they, were they restricted at your institution? Second question is, are you able to ascertain whether or not the patients who were undergoing resection with neoadjuvant therapy had a longer duration of the therapy or not? And then finally, a statistical question. You showed the overall volume. Is that an accurate measure, or would a more accurate measure be the percentage of cases that were done with neoadjuvant therapy than not? Thanks, and congratulations again.
Yeah, thank you. So in terms of the last question first, when paired with our other study, we saw that the rate of neoadjuvant therapy compared to total overall operative rate remained relatively stable during this time period. That being said, as part of the limitations, the total capture that we're getting for especially our colorectal mets with neoadjuvant therapy is still a little low, so we're trying to optimize it. In terms of duration of chemotherapy, that is one of the other limitations with this data set. We more or less have a binary, did they have therapy, did they not have therapy? And so we're unable to determine if people were just undergoing more rounds of treatment before they progressed to operative intervention. And I apologize, what was the first question one more time? Right. Yes, at our institution, no, our cases kept going. We were able to make the argument that, with the increased risk of disease progression, that these are, elective only in the sense that they are scheduled ahead of time and that patients still needed to be prioritized. And similarly, in the other half of this project, we saw overall that while there were transient changes, especially in the hepatic operations, overall the trends are that people across the nation continued operating and patients were still being prioritized. That being said, it still leaves a lot of room for granular detail about whether other therapies were being used, whether the outcomes are going to be different, and what else could have been done to improve care during that time.
All right. Any question from the floor? Any question from the moderators?
Can you comment if there was any regional variation?
Yep. So we were able to break up the data into 6 regions across the United States, and surprisingly, we saw that everyone had almost the exact same pattern. We had fully expected to see, as the pandemic progressed across from the East Coast outwards, that we would have seen regional changes, but it looks like everyone responded the same exact way with a hard shutdown in March and then pretty much keep going after that.
Thank you very much.
Thanks.
Well, next up is Dr. Qi Zhang from Mayo Clinic, Rochester, presenting quality of life and gastrointestinal symptoms in long-term survivors of pancreas cancer.
How do I advance? Hello, my name is Qi Zhang. I'm a surgery resident in Mayo Clinic in Arizona. Thank you very much for the opportunity to present our work on quality of life in long-term survivors following pancreatic cancer. We have no disclosures. Survival for pancreatic cancer has been improving over time, and this is in large part due to improvements in multimodal therapy. As the number of long-term survivors continue to increase, it's imperative that we be able to describe and to counsel patients on their quality of life after surgery. We began our analysis by identifying all patients who underwent a Whipple between 2011 to 2019 for cancer indications. These patients were subsequently divided into 2 groups: those who were long-term survivors or alive at least 3 years after the Whipple, and non-long-term survivors were those who died within 3 years. Of the long-term survivors, patients who were still alive as of June of 2020 were eligible to complete our survey, and within these 238 patients, we had 137 responses, making for a response rate of 58%. The median time from surgery to survey completion was 5 years, with a range of 3 to 11 years. Our cross-sectional survey itself had 2 primary components. The first is the EORTC, which is a validated tool that assesses quality of life. It asks questions about different types of functions as well as general symptoms. The second part is a pancreas-specific symptom survey. and it comprised of questions regarding disease status, surgical complications, diabetes, digestive issues, and overall quality of life. We began our analysis by comparing long-term survivors against non-long-term survivors. And similar to what we found in the literature, our long-term survivors had higher R0 resection rates. They were more likely to have non-elevated levels of CA19-9. They had smaller tumor sizes and less nodal disease. And while these were associated with long-term survival, they were not necessarily prerequisites. Next, to ensure that our responders represented all long-term survivors, we compared these two groups. And in our comparison, the two groups are fairly similar, with the exception of long-term survivors having undergone neoadjuvant therapy more often. So next, we assessed our EORTC data, comparing our long-term survivors against general population norms in the United States. And compared to the US population, our long-term survivors had better physical and emotional function. They also reported lower rates of nausea, vomiting, pain, dyspnea, insomnia, appetite loss, and constipation, although they did report higher rates of diarrhea. Overall, however, their quality of life was actually better compared to general population norms in the United States. Next, we assessed their different metrics within the pancreas-specific data. And when we asked patients what their disease status was, 87% of patients reported that they were cancer-free. And the majority of patients are still being followed for cancer care, though this was not all patients. Next, we assessed their recall of surgical complications, primarily asking them about delayed gastric emptying as well as pancreatic fistula, of which 10% and 7% of patients respectively recalled being diagnosed with these. And then we also assessed their postoperative diabetes outcomes. Of all long-term survivors who responded to our survey, 37% reported that they were diagnosed with either prediabetes or diabetes. 20% of these patients were diagnosed before their Whipple, while 17% were diagnosed after their Whipple. Of all patients who were diagnosed with diabetes, 51% of patients required insulin plus or minus oral agents, 21% required oral agents only, and the remainder 28% required no medications. Interestingly, when we analyze patients who were diagnosed with diabetes after surgery, 48% of them required insulin plus or minus oral agents. Next, we assessed digestive symptoms, starting with acid reflux. 45% of patients reported that they still required reflux medications, and interestingly, more than half of these patients were diagnosed with ulcer disease. When we asked patients about their pancreatic insufficiency, 53% of patients recalled being diagnosed with this. However, 60% of patients reported that they were still on enzyme supplementation at least 3 years after their operation. And in terms of their symptoms that they were still experiencing, 55% of patients reported that they were experiencing diarrhea more than once a week, but pain and bloating occurred slightly less often, with 35% and 40% of patients experiencing these symptoms more than once a week. However, most patients reported that they were not limited by the type or the amount of food that they were able to tolerate. Next, we assess quality of life in patients based on specific complications. And interestingly, though more patients were affected by diabetes and GI symptoms, only 8% and 17% of patients reported that these either had quite a bit or very much negative impact on their overall quality of life. And this is in contrast to patients who were diagnosed with delayed gastric emptying and pancreatic fistula. Though fewer patients were affected by these, a much greater proportion of these patients were reported that these had negative impact on their quality of life at 25% and 50% respectively. However, when we asked patients if they would choose surgery all over again, given the option, the overwhelming majority of patients reported that they would. Of course, our study is not flawless. We began our analysis by collecting patients in a single-center retrospective cohort identification method, and the cross-sectional survey design also introduces biases of its own. Starting with recall bias, as our patient cohort had a surgery to survey time range of anywhere between 3 to 11 years. However, when we actually analyzed this much more closely, we did not really see a relationship. This graph plots time from surgery to survey in years on the x-axis and quality of life from 0 to 100, 100 being the best and 0 being the worst on the y-axis. And as you can tell, it's truly a scatter plot without a real pattern. Our concerns were also further mitigated by the fact that we were interested in long-term outcomes as opposed to asking patients to recall events from 3 to 11 years ago. So most of our questions were focused on current symptoms. Finally, we were also limited by survivorship bias as we purposely chose to only survey patients who are long-term survivors after treatment for their pancreatic cancer. Overall, we saw that long-term survivors had excellent quality of life, especially when compared to the general population in the United States. Our data on long-term complications, as well as their specific rates, such as for diabetes, pancreatic fistula, and pancreatic insufficiency, should be used for preoperative education for the patients, as well as for guidance for follow-up planning. Thank you very much for your time.
Thank you. I'd like to invite Dr. Cho from University of Oklahoma to discuss his paper.
Thank you. Congratulations on your study. It's excellent. I'm going to actually steal some of your numbers when I have discussions with my patients. A few things. I found one of your numbers very interesting about the neoadjuvant therapy, the patients being more satisfied in terms of quality of life after neoadjuvant, but not adjuvant. Why do you think that is?
So neoadjuvant versus I think our data showed that neoadjuvant therapy was more common in patients who were long-term survivors compared to non-long-term survivors. And when we looked at that data more specifically, it was because the patients who responded to our survey tended to have surgery in more recent years. So I don't necessarily know that we can conclude that neoadjuvant therapy necessarily increased patients' quality of life after surgery. But that's not necessarily to say that that isn't true. It's just that we didn't specifically analyze for that.
Well, I don't know if there was a change in patient perception getting chemo first and then upfront and then surgery, or upfront surgery versus getting chemo afterwards. But I thought that point was interesting on your study. Your respondent rate was, which you can extrapolate survivorship off of, because obviously you have to be alive to respond to your survey, was pretty impressive too, because I think you had over 50%.
It was 58%
plus 3-year respondents, which is really great. We're moving towards more minimally invasive for Whipples and whatnot, laparoscopic and robotic. I was wondering if that was included or that was looked upon in your survey in terms of quality of life and satisfaction.
We did not specifically analyze that, but we certainly can collect that data from our REDCap database. So I'll be sure to look into that for the manuscript.
Congratulations again.
Thank you very much.
Matt Walsh from Cleveland. Congratulations. It doesn't surprise me that people who are out 3 years after pancreatic cancer aren't have a good quality of life, because they feel very appreciative. They know the odds. My question is, what did you and your group learn from your own analysis of your data? It seems to me the one thing that I'm constantly managing is exocrine insufficiency, because that's what no one else will consider even in these patients. So what did you think about the 60%? It seemed like people were still having symptoms. Do you check fecal elastase routinely? How many people didn't use pancreatic enzymes because they couldn't afford it or weren't supported?
Yeah, that's a great question. And quite honestly, we were quite surprised by the fact that 60% of patients were still on pancreatic enzyme supplementation. We did not necessarily ask patients if financial difficulties were a part of their care for their pancreatic insufficiency diagnosis. However, there was a separate analysis that looked at financial toxicity, and we didn't really see an impact on their financial burden on their quality of life. Having said that, we'll be sure to look into that a little bit more closely as well.
Great paper, Bart Rose at UAB. And I may have missed this in the analysis, but did you break down this on type of resection? Was there a higher chance of being on insulin with a distal pancreatectomy or pancreatic insufficiency with a Whipple?
So all of our patients only had Whipples.
Only had Whipples. Okay, I did miss that. Thank you.
Yeah, thank you.
And to add to that, did you examine the role of gender or social determinants of health in your responses?
So interesting that you bring up gender. In our analysis, when we looked at patients who reported that they would choose surgery all over again, most patients reported that they would, but we were curious about the 10 to 12% who said that they wouldn't. And the only demographic factor that was significant statistically was actually female gender. Having said that, a sample size of 12 is not really sufficient to draw any real conclusions from it. But we also looked at their responses on the actual EURTC survey, and it seemed like most of the patients there wasn't really a real factor as far as if they were diagnosed with more specific symptoms that would lower their quality of life metric. Although some of the patients who scored very low on the quality of life metric itself had more functional issues, like I had difficulty carrying my suitcase up the stairs, or patients suffered from depression and anxiety.
Yeah, and also stratification by age groups.
Pardon?
Stratification by age groups, by decades or age groups.
That would
See
be
if the young or the old and better.
we didn't look at that, but I will.
All right, thank you.
Thank you.
Thank you very much.
Okay, the third paper is earlier time to intervention shows improved outcomes for necrotising pancreatitis in select patients. Our presenter is Tania Torres-Rui from ProMedica Toledo Hospital.
Hi, everyone. My name is Tania Torres. I am a general surgery resident at University of Toledo ProMedica Hospital. Thank you so much for allowing me to present here at AHPBA. I'm going to be presenting a NSQIP analysis that reveals earlier timed intervention is associated with improved outcomes for acute necrotizing pancreatitis patients. I have no conflicts of interest. So pancreatic necrosis develops in 20% of acute pancreatitis. 30% of these patients ultimately develop superimposed infection, which if left untreated, 40% develop organ failure, which can be associated with 30% mortality. The PANTHER trial, which was published back in 2010 in the New England Journal of Medicine, was a landmark paper that shifted our management towards minimally invasive approach. It looked at two cohorts, those that underwent open necrosectomy up front and those that underwent the step-up approach, which was a focus on delayed operative intervention and minimally invasive procedures. Ultimately, the trial showed a decrease in morbidity with the step-up approach, but no real difference in mortality. And ultimately, 2/3 of the patients still required operative intervention. As of now, we can't say that there is a definitive conclusion on optimal time to operative intervention. So the aim of our study was to assess the effective time to operative intervention on the outcomes of patients with acute necrotizing pancreatitis. Our hypothesis was that earlier intervention may be associated with equivalent or improved outcomes compared to delayed intervention. We used the NSQIP database from 2016 to 2020 to identify patients with necrotizing pancreatitis who underwent pancreatic debridement necrosectomy or pancreatectomy. We further divided these patients into two different groups, those with non-infected necrotizing pancreatitis and those with infected necrotizing pancreatitis. We further stratified our patients into 5 groups based off of time from admission to operative intervention. Those groups were 0 days, 1 to 3 days, 4 to 12 days, 3 to 24 days, and greater than 24 days. The primary outcomes that we ultimately looked at were 30-day postoperative rates of unplanned readmission and 30-day mortality. Our secondary outcomes were major complications that included pneumonia, intra-abdominal abscess, acute kidney injury, unplanned intubation, failure to wean off the ventilator, which was defined as greater than 48 hours, unplanned return to the operating room, perioperative transfusion required, venous thromboembolism, and septic shock. We identified a total of 390 patients with acute necrotizing pancreatitis that underwent operative intervention. The mean age of these patients was 52 years, with 70% being male, 73% being white, and approximately 30% having an ASA class 4 or higher. The mean length of stay was 13 days, and the mean time to operation was 3 days from admission. Longer times to operative intervention did show that there were higher odds of 30-day mortality and major complications, and this remains significant on our sub-analyses of both infected and non-infected necrotizing patients. When looking at our demographics, we saw that comorbidities such as ascites, dialysis dependence, chronic wound infection, and ASA class 4 or higher were associated with delayed time to operative intervention. And when looking at the preoperative lab values, we saw that patients who had an increase in the white blood cell count and BUN did have delayed time to operative intervention, while a lower hematocrit and albumin were associated with delayed time to operative intervention. This was also true for our group with infected necrotizing pancreatitis. When we looked at the 30-day major postoperative complications, we did note that in all patients with necrotizing pancreatitis, we had an increase in those major postoperative complications as time to operation was extended. This was also true for both our non-infected necrotizing pancreatitis patients and infected. When we looked at the 30-day postoperative mortality, we saw that all patients with necrotizing pancreatitis also had an increase in the mortality rate as time to operative intervention was delayed. This was statistically significant in our non-infected necrotizing pancreatitis patients. And although not statistically significant in the infected necrotizing pancreatitis patients, there was a trend of increasing postoperative mortality. When we performed our multivariate analysis, it was interesting that both the early and later time to operative intervention groups, the 30-day mortality did show a decrease. However, the later group or the later intervention group did have a twofold increase in the major complications. When we looked at both the infected and the non-infected necrotizing pancreatitis patients, this also was shown to be true. So ultimately, necrotizing pancreatitis remains one of the most morbid diagnoses. Our current recommendations focus on delay of operative intervention. And despite the recommendations of the PANTHER trial, earlier operative intervention is actually frequently undertaken. Our study shows that earlier time to operative intervention can be performed with equivalent mortality, but significantly less morbidity. And as such, we believe that the dogma of delayed operative intervention should be reevaluated. Thank you.
Thank you. We'll invite Matt Walsh from Cleveland Clinic Foundation to discuss.
Thank you very much. Nicely presented. Thank you for getting me the manuscript, which I think I read 5 times because I couldn't quite understand it. So this is a very provocative study, right?
Right.
If I summarized it, 50% of the patients were operated within 3 days from their index admission for necrotizing pancreatitis,
Right.
30% within a day, which is when we're not even getting the CT scan to look for necrosis, and 50% but had infection, which is supposed to be a delayed event. So I'm just confused about who these patients are really. And let's start with NSQIP. You used ACS NSQIP with the 700 hospitals, not the ACS NSQIP.
Right.
So does that exclude the 114 that are in ACS NSQIP or not? And why did you pick that database instead of the one that would give you more granular results of pancreatectomy?
Right, that's a very good question. And I believe that's just the database that we had available at the time, but I think it's definitely something that we could look into in the future.
So what you also, your supposition, by the way, is that the reason that these people did better is because we have better ICU care. That's what the manuscript says. Right. So I guess it begs the question, if we're really doing great with ICU care, which is great, why did they need to leave the ICU to go to the OR at all?
Right. And I think, looking at the variables that we have available on the NSQIP database, again, we can't really define how severe the pancreatitis was or what which is one of the limitations of the study. But we can't really say specifically why that patient went to the operating room at an earlier time.
And not only that, remember, right, there were 350 patients you didn't bring up here, right, that you didn't get operations, but also had necrotizing pancreatitis. Right. So when you talk, the title talks about patient selection, right? Select out. What is that? How do we do that?
So unfortunately, again, I think that we can't make any definitive conclusions. We can only look at the demographics, and although they give us maybe a small idea as to what patients were operated on earlier, I think in general it would be a prospective study that would be needed in order to fully have a conclusion as to what select patients we can look at. And I know our institution is a high volume center that treats acute necrotizing pancreatitis patients. I think that we can do that in the future.
And lastly, I wasn't clear about the operations that they actually got. So you talk about minimally invasive approaches. I mean, one of the concepts is the reason to wait is to some people actually won't need any operations. You'll get walled off necrosis, which would afford minimally access procedures. So within 3 days, what are these operations? Are they all laparotomies? Are they, how many of them? You included necrosectomy, debridement, and resection. How many of them were resection?
So I don't believe we have an exact number, so I will have to look into that for the manuscript. But I think you brought up a good point with regards to the minimally invasive approach. And again, unfortunately, we only have the CPT codes for the operations, and there is certain minimally invasive approaches that didn't have CPT codes that we had available. So that was something that we couldn't look into.
It sort of comes across as a database mine that I'm not sure how I'm going to use the information.
All right, thank any other questions from the audience or the moderators?
Yeah, I mean, I have the same feelings as Dr. Walsh, but if you look at the pathogenesis of acute pancreatitis, I think the only the only plausible reason for doing laparotomy within the first 3-4 days from the index event is putting some drainage for a peripancreatic fluid collection, which is, I mean, it's pointless. You know, you don't have the time for necrosis to develop. So it's not walled off necrosis by definition. It can just be peripancreatic fluid collection. So I'm very surprised by these results, actually. Very surprised. But it's not up to you. It's administrative database, so it's not up to you.
One of the things that I thought that maybe is that most of these hospitals are referral centers, and these patients, you define date of admission, but they were probably somewhere else and deteriorated and transferred in. So that's the only way that I thought that this could actually exist. I think that's the time that we have. Thank you very much for your presentation.
All right. So next one is the implication of an isolated positive vascular groove and after Whipple for PDAC. Dr. Kelly Halavin from, is it correct? No, I'm sorry about that. I tried 3 or 4 times pronunciation, but I failed. Sorry about that. From Pittsburgh.
Yes, it's Callie Halavin, but good attempt, better than most. Thank you so much for having me. I'm Callie Halavin. I'm from the University of Pittsburgh. I'm honored to be here this morning sharing our work. I have no disclosures. So all of us in this room think that pancreas cancer is the most interesting thing to research, but objectively it's important because pancreatic ductal adenocarcinoma is the 4th leading cause of cancer-related deaths for both men and women in the United States, according to 2022 data. And this is expected to rise to 2nd by 2030, according to some modeling done by an MD Anderson group. And that would put pancreas cancer deaths ahead of both colorectal and breast cancers. Now, surgical resection is the only potential cure for pancreas cancer, and our margin status is an indicator of surgical quality as well as patient outcomes. So what you can see here in this meta-analysis is that patients who have R0 resections have far superior survival compared to those with R1 resections. And this is what we see reflected day to day in our clinical practice. However, margin definitions and implications are constantly changing. Now, this is not news to you guys, but traditionally our Whipple transection margins include the pancreatic neck, the bile duct, the proximal and distal enteric margins, and the uncinate and the retroperitoneal margin. But there are other important areas of the Whipple specimen that sometimes get left behind, and these are referred to as the circumferential resection margin. Now, this includes the peritonealized anterior surface of the pancreas, as well as the posterior and medial surfaces, which I've shown you here. The yellow markings indicate the vascular groove, and then the uncinate margin is just to the right of that, oriented a bit more posteriorly. Now, the assessment and the interpretation of these often are not included by the pathologist other than the uncinate margin, but they're important because they're often affected by positive margin status at the time of our resection. And importantly, the College of American Pathologists no longer considers the vascular groove a resection margin, but rather a surface of involvement. So given that the clinical significance of the vascular groove remains debated, we aim to evaluate the impact on overall survival and disease-free survival of an isolated positive vascular groove following Whipple. So we performed a single center retrospective study of the UPMC pancreatic cancer database of patients who underwent Whipple for pancreatic cancer between 2006 and 2019. Now, we included two groups. The first group is an R0 resection with tumor greater than 1 millimeter from the resection margin. And the second is our R1 resection group, that defined as tumor less than or equal to 1 millimeter from the resection margin, where the vascular groove was the only positive margin. Now, this group included two different types of patients. One who had no vein resection, where the tumor is essentially peeled off of the vascular groove, and the second where there was a vein resection with no tumor involvement into the vein wall. Now, importantly, we did exclude patients who had a vein resection with direct tumor involvement into the vein wall. And our primary outcomes included overall survival and disease-free survival. So you can see here that we had 177 patients in the R0 group and 57 patients in the positive vascular groove group. Now, of those 57 patients, 30 of them, or just over 50%, did have a concomitant vein resection with, again, no direct tumor involvement into the vein wall. And what we see is that the demographic characteristics are similar. Likewise, the CA19-9 values are similar. And the days from diagnosis to OR are similar here. Now, in terms of preoperative resectability and neoadjuvant therapy, we see that the resectability status between the R0 and the positive vascular groove groups are similar. And likewise, the receipt of and type of neoadjuvant chemotherapy between those groups is similar. However, we do see that the R0 group received more neoadjuvant radiation compared to the positive vascular groove group. Now, this is a complicated slide, but it shows tumor pathology, operative characteristics, post-operative therapy, and recurrence variables. What we can see here is that the R0 group had a larger number of smaller T1 tumors. The positive vascular groove group had a larger number of T2 tumors, and that the number of T3 tumors between the groups was similar. Now, by definition, the R0 group did not have any cancer at INC, and about 12% of the positive vascular groove group did have cancer at the margin. Now, in terms of positive lymph nodes, lymphovascular invasion and perineural invasion, we see higher rates of all three in the positive vascular groove group. And really, this is an indicator we think of more aggressive tumor biology in that group. When we look at type of vein resection, they're similar between the two groups. However, when we look at adjuvant chemotherapy, we see higher rates of both adjuvant chemotherapy and adjuvant radiation therapy in our positive vascular groove group. Again, not surprising given the positive margin status here. Interestingly, when we look at the first site of recurrence, we see our typical pattern for the R0 group, right? So 25% local recurrence and 75% distant recurrence. And then we see in the positive vascular groove group, a much, much lower rate of local recurrence at about 5%, and then a consequentially higher rate of distant recurrence at not over 95%. And we think this is probably secondary to the higher rates of adjuvant radiation therapy in this group. Now, we did univariate and multivariate analysis with our outcome being overall survival. Here, follow-up was truncated to 60 months. I just include here for brevity's sake the univariate modeling for the margin status, although it was done for all of the variables previously described. So you see no difference in overall survival based on margin status. And then in our multivariate modeling, only adjuvant chemotherapy had an association with improved overall survival. Again, similarly, we did univariate and multivariate analysis with our outcome being disease-free survival. Again, for time's sake, I just include margin status from our univariate modeling, and we see no association here with our margin status and disease-free survival. In terms of our multivariate model, we just see that locally advanced resectability status is associated with worse disease-free survival. None of our other variables here are significant. Okay, so here's our Kaplan-Meier curve for overall survival, and you see here no difference between the R0 and the positive vascular groove groups with a p-value of 0.2. Likewise, in our Kaplan-Meier curve for disease-free survival, no difference between the two groups. Now, of course, there are several limitations to our study. First, it's retrospective study design. So by nature, we can't make any causal inference here. We have relatively small sample sizes, 177 versus 57. So that limits a little bit our power and what we can include in our multivariate modeling. And of course, our positive vascular groove group does include those two unique cohorts that I mentioned, those who had no vein resection when the tumors peeled off, and those who had a vein resection with no direct tumor involvement into the vein wall. And we do recognize that these two groups could be heterogeneous and they may have different behavior and outcomes, but we do group them here for numbers' sake. So in patients undergoing Whipple for PDAC, the presence of an isolated positive vascular groove, either without a vein resection or a negative vein resection, have equal outcomes compared to our R0 resection. Thank you very much. I'm happy to take comments or questions.
Thank you. We'd like to invite Dr. Patricio Polanco from UT Southwestern Dallas to comment.
Thank you so much. Dr. Halavin?
Yes, that's correct.
It's not that difficult. Dr. Mario, it's not that difficult, okay? I just heard it for the first time now. Thank you for letting me, for getting the paper to me in advance and for a very nice delivery of the talk. I have a couple questions. The first one, I hope, easy to address. I think is great in the analysis. You excluded those that were clear invasion of the veins. But however, I think part of the flavor of your presentation or your topic is, often we do vein resections that we may not need to be done. And now you're also saying that if they are focally invaded, maybe even it's not necessary to resect the vein because it doesn't affect outcome. So I'm curious about what is the number of patients that were excluded with frank vein invasion, because that gives you the true denominator of the vein resections. That's my first question. The second one, these are all resected patients, right? So when you break down in, resectable, borderline, and local advanced, you're talking about resectable local advanced pancreas cancer, which we all talk about. And increasing rate, we're all doing it more and more often. And given that local advanced feature was the only disease-free survival parameter that panned out to be relevant in your multivariate analysis, I guess for DFS, what is that population like? Because you have R0 resections, you have isolated vein invasion in this group, in the second group, but why was there considered local advance? Make sense? So what was the feature anatomically? I'll stop there. Maybe you can answer those two.
Yes, I'll start with maybe your second question. If I understand correctly, you're asking me what of their locally advancement made them resectable?
The opposite. What was the feature that makes them locally advanced?
Unfortunately, I don't have that type of granularity with this. I don't know the answer. I guess the short. Unfortunately.
Yeah.
So.
And
the first question.
Yes.
Remind me.
The number of patients excluded with frank vein.
So we have preliminarily looked at those who had a vein resection with that vein resection being positive. If I remember correctly, it's about 27 patients. Unfortunately, I don't have that data to share today, but from what I remember from the prelim analysis, they do have worse outcomes compared to both of these groups.
That makes sense. And I guess my last question, which essentially blend with a comment. It appears from your presentation that you did not include the isolated vein invasion in the multivariate analysis because it ended up not being significant in the univariate. But I think you need to force it into the model because because clinically relevant, that's the centerpiece of your paper. Moreover, your conclusion says that disease-free survival and overall survival may not be relevant whether it's isolated invader or not, but that could be artificial as well. You show that there is better survival in this group, but also your data, I got a little nerd out in the numbers, so bear with me. The adjuvant radiation therapy was 45% in that group. The adjuvant chemotherapy was 88%. Versus 10 and 66. So these patients got much more chemo adjuvantly. They got much more radiation adjuvantly. And that may explain why they live longer. And not only that, they have much lesser rate of local regional recurrence in comparison with the R0 group. So I think for the take-home message is maybe there's no difference as long as they get heavily treated perioperatively.
Yeah, and that may be true. If you look at the recurrence rate, though, in general for the two groups, it's about 58% for the R0 group and almost 75% for the positive vascular groove group. While it didn't reach significance, I think it trends towards there being more recurrence in that positive margin group. However, correct. However, more likely to be systemic. But I think you're right in terms of we're probably seeing a strong effect from the higher rates of adjuvant chemotherapy and radiation therapy.
I think in the era of neoadjuvant therapy, the positive or isolated positive margin may not be as relevant as it was earlier in your series in 2006. But I think I would just tune down a little bit the final conclusion. Otherwise, great paper. Thank you.
Thank you.
All right, Dr. Walsh.
My first question is, who does the marking of the margins? Does the surgeon do it at UPMC? Because I think you should.
You mean
does
in terms
that
of
happen?
inking the margin ourselves?
Yeah.
I don't believe that we do that ourselves. I think that's done
That's
by
a great
pathology.
quality project that I would encourage you to do, so you know exactly what you're looking at. I don't know what I should take away from this. And my one question is are any of these patients getting neoadjuvant chemo radiation therapy?
I think, I don't know about the combination of the two. I don't know if I have that information to share, but it did show that the R0 group did get higher rates of both neoadjuvant chemotherapy and neoadjuvant radiation therapy.
Because that's where it may be difficult to tell what's invasion or not, what's the radiation effect. So, when you include the ones who it was negative once you had done the vein resection, that doesn't help me decide whether I should do a vein resection or not, right?
Right.
So I happen to think there are a lot of minimally invasive Whipples being done at UPMC. So how do you tell whether you should do a vein resection or not? This would seem to imply just go ahead. As long as you stay out of the vein, you're going to be okay.
Right. And that's a great question. I think as to a nod to all the surgeons in the room, if you can peel the vein, if you can peel the tumor off the vein, you will, right? If you don't have to do a vein resection and subject the patient to that morbidity, you certainly will do that. I think here we're showing that even if you do need to take a tangential side bite of the vein, the patient's going to have a similar outcome as long as you can keep that vein negative. So, of course, we like to peel as much as we can, but that's not always the case, unfortunately.
All right, two quick things.
Thank you.
Sorry.
No, it's okay.
Just technical details. I was surprised about the concept of circumferential margin in the United States. This involves an axial slicing.
We don't.
Was this performed?
No, we don't do that. It's just in the introduction to get your mind ready.
So it's not circumferential margin.
We do not do that in our pathology specimen. No.
It's venous groove. It's different.
Great. Yes.
And do you normally do tumor vessel biopsy at the tumor vessel interface for frozen section when a venous invasion is suspected intraoperatively?
I don't know if that's routinely done.
You just try to peel off,
Yeah.
and if it doesn't, you do vascular resection.
Correct.
All right. Thank you.
Thank you.
Next up is Dr. Hannah Trembath from University of North Carolina, presenting Moving Towards a Blood-Based Assay for Molecular Subtyping of Pancreatic Adenocarcinoma.
Good morning. My name is Hannah Trembath. As mentioned, I'm from the University of North Carolina. I'm a general surgery resident there. And today I'm going to be talking about our work in moving towards a blood-based assay for the molecular subtyping of pancreatic adenocarcinoma, or PDAC. I have no disclosures. So PDAC is an extremely lethal disease with poor long-term survival. Our lab has previously shown that there are two tumor-intrinsic molecular subtypes, basal and classical, and that these subtypes are both prognostic, with the basal subtype showing worse overall survival compared to classical, as shown here in this Kaplan-Meier curve, as well as being predictive of treatment response, with the basal subtype showing increased resistance to FOLFIRINOX therapy. When we analyzed two clinical trials, the COMPASS and the Linehan trial, we found that patients with the basal subtype showed increased tumor size growth while on FOLFIRINOX therapy compared to patients with the classical subtypes, which typically showed some tumor size regression. Currently, molecular subtyping is done through RNA sequencing, and it requires an invasive procedure to get tissue needed for diagnosis. That takes time, is costly, and is not without risk to the patient. So what our lab is asking is there a less invasive way that we can go about getting a patient's molecular subtype? We know that there's abnormal methylation in cancer cells compared to healthy non-cancerous cells. And we also know that there is circulating tumor DNA and circulating tumor cells in the blood of cancer patients. And so there already are commercially available tests that make use of abnormal methylation in cancer screening. Previous work in the field has been done to show that there are differential methylation patterns between the two subtypes of PDAC. And so what we're asking is, can we leverage these two things? The fact that there's differential methylation between the two subtypes and that there's circulating tumor DNA in the blood of our patients to potentially develop a blood-based assay for subtyping. So to develop our methylation-based classifier, it was a series of steps that I'm going to walk us through in more detail. And Des Weighill is a postdoc in our lab who's been instrumental in developing this model. First, to do preliminary training of our model, we utilize the Cancer Genome Atlas PDAC dataset, which is comprised of 150 primary pancreatic tumors. We need both methylation data for our classifier as well as RNA sequencing data to do our subtype analysis. And from this data set, we are able to identify subtype-specific methylation patterns between the two subtypes. And we were able to identify the most important methylation probe sites. We selected the top 20 methylation probe sites, 10 that are highly methylated in basal and 10 that are highly methylated in classical for our model. So a random forest model is a descriptive model that's typically used in classification. The data is run through a series of decision trees that each vote on the subtype, and then the majority vote gives you your final result. Now that we had our model, we're ready to move on to validation. So we utilize the other publicly available data set that has both RNA sequencing and methylation data, the International Cancer Genome Consortium data set. And with this data set, our model did well. We were able to predict 15 out of 16 basal subtypes and 62 out of 66 classical for a total sensitivity and specificity of 94%. We then turned to our own PDX repository, so patient-derived xenograft tumors. And to get the methylation data from that, we used a tool, we use Epic Array. Epic Array is a tool that allows you to quantitatively detect the total methylation in the genome at over 450,000 sites. And with the methylation data from the Epic Array, we were able to predict all 21 of our PDX tumors subtype. However, Epic arrays are not clinically feasible as they're expensive, they require a lot of DNA, and we wanted to translate our classifier now to a more clinically usable platform, and so we started with qPCR. To be able to do qPCR, we needed to develop primers that would selectively amplify the DNA at our target sites of interest. Once we developed those primers, we were ready to do a qPCR run. We took 10 of our PDX DNA, 5 basal, 5 classical, and with the data from our qPCR, we were able to predict all 10 of these subtypes. So this figure here on the right shows you an example of our classical target site and a basal target site. Along the y-axis is the CT value or the threshold cycle value that's inversely correlated to methylation. And so at the classical target site, you can see the clustering of the classical samples at the lower CT value or higher methylation. And similarly with the basal clustering at that lower CT value. We wanted to verify that our probes were selectively amplifying the methylated DNA at our sites of interest, that correlated with the methylation data that we had from Epic arrays. And what we found is that the methylation of the two, the qPCR and the Epic array, were strongly correlated. So this figure here on the right is from 4 of our target sites. And you can see along the y-axis is the methylation data from the qPCR, and along the x is the EPIC array methylation data. And you can see that there's a strong correlation here, as well as a continued clustering by subtype. And so what I've shown today is that we've successfully developed a methylation-based classifier to correctly predict subtype with using a minimal number of sites. We're now working towards digital droplet or ddPCR, as this is more sensitive than qPCR. It also allows you to use lower concentrations of DNA. And we believe that this has a significant clinical promise. This is our lab. A special thanks to Des and Dr. Ye for being great mentors, and I'm happy to take any questions.
Thank you. Nicely presented. I'd like to invite Dr. Samir Patel from University of Cincinnati to discuss.
I want to congratulate Dr. Trimbath and our colleagues for a really exceptional work. These data are very impressive. I had two questions. First, I'm a little bit interested in hearing more about the methylation targets you used. Were they similar genes or ultimately protein targets that you originally used to classify basal versus classical subtype? And then also, were you able to get any sense of whether there was normal or activated stroma based on this? And then secondly, as you had mentioned, your group also showed that, there's differential response to FOLFIRINOX, for instance, based on basal or classical subtype. Could you and did you use this classification profile with methylation to determine if you similarly saw that type of response if the samples were treated with chemotherapy? And then especially if there was a phenotypic switch, such as from basal to classical or vice versa?
Yeah, thank you for your questions. So in regards to the first question with how our methylation sites corresponded to our genes used in our initial paper looking at the two subtypes, 3 of the 20 sites are in or near the genes that we use in our Moffitt classifier. However, even though only 3 overlap, there is significant correlation between the sites of methylation and the genes that they regulate with our Moffitt genes. With your question on the pre and post, if there's methylation changes, we've never looked at the methylation changes pre and post. We don't have that data. When we've looked previously at pre and post biopsies, the overall molecular subtype has not changed. So with the Linehan trial, where we had 28 patients that had paired pre and post biopsies, their subtype did not change. However, there was some slight shift in their tumor compartments. This just emphasizes the importance, how we need to integrate the pre and post treatment biopsies into further studies to be able to better selectively look for more effective treatments and guide therapy. You also asked about if we could use our classifier for activated or normal stroma, and we've not yet looked into that.
Thank you. Congratulations.
Yeah, thank you.
Josh Dada, University of Miami. Dr. Trembath, congratulations to you and your group for being on the vanguard of really defining molecular subtyping pancreas cancer. So, I think you'd agree with me that, based on the purest classification that you guys have, that there is a dosage in every patient's tumor between basal and classical. Mm-hmm. It's not a dichotomous yes or no, it's not black or white. And so I wonder how you plan to sort of statistically, as well as at a methylation probe level, sort of distinguish that or in patients, because patients are going to have a dosage of basalness and classicalness. And how are you going to use that to select your therapies, particularly chemotherapy switches, Dr. Patel mentioned? Mm-hmm. Thank you.
Yeah, thank you. So as you mentioned, tumors are heterogeneous. It's a hard word. The question about how clinically that impacts is there's kind of a threshold, we believe, between basal and classical. And with our previous work, we know that with our classifier, by differentiating into that, we are seeing treatment differences. And so with our methylation-based classifier, we think that we can further refine it as we get more information about how that could kind of guide therapies or change.
All right. But for your methylation probe, you're going to have a yes or no answer for each probe, correct? Yes. So say you have 3 probes that light up for basal and 3 probes that light up for classical in a single tumor. How are you going to reconcile that for an individual patient?
So using the model, we're able to analyze all of those different methylation statuses, and it still gives us a binary, but you can have some variation within the target sites. Not every basal subtype has all 10 or all 20 of the sites saying basal.
The last
Sorry
question
if I'm
from-
not.
No,
if I'm not
the last question. Are you looking? So you're looking at the ctDNA component, but are you looking at the plasma-free, cell-free component as well for the methylation status? Or are you looking just at the tumor DNA compartment?
All of the work that I've talked about is the tumor DNA, and what we're now working towards is doing the testing with the ddPCR with the plasma using the cell-free DNA.
Okay, nicely done. Thank you.
Thank you.
I think I broke it.
Okay, our next paper is going to be presented by Dr. Amirian from the University of Miami, Miller School of Medicine, and its nodal metrics after neoadjuvant therapy to refine selection for adjuvant therapy in resected PDAC.
Good morning, everyone. I would like to thank the organizing committee for the honor of presenting our work here. And we have nothing to disclose. So as we all know, pancreatic ductal adenocarcinoma, or PDAC, is a lethal malignancy, and the dismal oncologic outcomes with surgery alone in patients with potentially operable PDAC have necessitated a multimodality approach for this disease. In recent years, there has been increased momentum towards neoadjuvant chemotherapy, even in resectable disease, with several advantages, such as those that listed here in the slide. In those selected for neoadjuvant therapy, it is unclear, however, which patients can benefit from adjuvant therapy. In contemporary practice, selection of adjuvant chemo is typically guided by high-risk features on final pathology, such as node positivity and also suboptimal post-neoadjuvant therapy tumor regression. Indeed, a recent international multi-center study, sorry, it has to be, yes, that's correct. A recent international multi-center study revealed that the relative benefit of adjuvant chemo in patients receiving neoadjuvant FOLFIRINOX and surgery was restricted to subsets with pathologic node positivity. The goal of our study, using a multi-institutional North American data set, was to evaluate the interaction between post-neoadjuvant therapy lymph node metrics and relative benefits of adjuvant chemo in PDAC patients. We reviewed patients with potentially operable PDAC who received neoadjuvant either modified FOLFIRINOX or Gemabraxane with or without radiation, followed by pancreatectomy at 7 high-volume centers participating in the Central Pancreatic Consortium, or CPC, that is reflecting the institutions listed here on the left side. So overall survival using Kaplan-Meier log-rank estimates in patients receiving or not receiving adjuvant chemo was stratified by post-neoadjuvant therapy, lymph node status that was dichotomized to either positive or negative, and lymph node ratio that was defined as a number of positive nodes over total number of nodes. And we dichotomized lymph node ratio at 0.1 due to its prognostic discrimination, insensitivity, and also area under the curve analysis. We also did separate Cox models evaluating the independent association between these lymph node metrics, adjuvant chemotherapy received, and overall survival. So out of 464 patients, slightly more than half of them received adjuvant chemo and the other half didn't. We compared clinical demographic characteristics between cohorts. Patients selected for adjuvant chemotherapy, they were younger, more likely to receive modified FOLFIRINOX as neoadjuvant chemo regimen with a slightly shorter duration, and less likely to have severe postoperative complications. So as mentioned previously, we evaluated the association between post-neoadjuvant therapy, lymph node status, and lymph node ratio with overall survival in 2 different models. As shown here, both lymph node positivity and lymph node ratio more than 0.1 were independently associated with increased risk of mortality in their respective models. In addition, modification of neoadjuvant chemotherapy dosing, postoperative complications, and also peripheral neural invasion, they were also independently predictors of overall survival in both models. So here, I'm showing you the Kaplan-Meier curves for the association between overall survival and post-neoadjuvant therapy lymph node metrics. On the left side of the screen, you can see that lymph node positivity in the green curve after neoadjuvant chemo was associated with worse overall survival. And on the right side, the higher lymph node ratio, that is we define as above 0.1, also in green, was associated with worse overall survival. However, conversely, the receipt of adjuvant chemotherapy was not associated with improved overall survival in this cohort. So evaluating the interaction of lymph node metrics with receipt of adjuvant chemo, in contrast to the international multi-center study that I mentioned earlier, we didn't see improved survival with adjuvant chemo in the lymph node positive cohort, as shown here in the green curve, that the solid and the dotted curves. However, interestingly, we did see an association with improved overall survival in patients receiving adjuvant chemo who had higher lymph node ratio, that is above 0.1, shown again in green, after neoadjuvant therapy, but not in patients with lower lymph node ratio, less than 0.1, that is shown in orange here. In conclusion, lymph node ratio following neoadjuvant therapy, not simply nodal positivity, may be useful to refine selection of adjuvant chemotherapy in patients with resected PDAC. While strong recommendations cannot be offered from these data, given substantial heterogeneity that we saw in chemotherapy selection and delivery patterns across institutions, our findings call for a more nuanced patient and biology-driven approach to adjuvant therapy selection following neoadjuvant therapy and resection for localized PDAC. And I would like to finally thank my amazing mentor and surgeon scientist, Dr. Josh Dada, and the CPC team with the institutions participating that made this happen. And I'm happy to take any question.
Thank you. We'll invite Dr. Parikh from Rochester Regional Health to discuss.
Thank you very much for this presentation and looking at something that's actually a very important topic for patients, because you want to try to give them the best chemotherapy as little as you can and just as much as they need, and not over the amount that they need. And for patients, I have some questions about this study because it involves so many different institutions where you've collected data. The first thing is, what was the type of chemotherapy as well as the duration of chemotherapy that each of them got? For example, a lot of institutions have different ways that they give it. They give 6 cycles of neoadjuvant chemotherapy. They gave 8 cycles of neoadjuvant chemotherapy, or 12 cycles of it. So that's one question. And how was that reviewed and balanced? The other question is was there any radiation involved in any of the patients getting any chemoradiation neoadjuvant? And there's obviously a little bit of selection bias going on who's getting some adjuvant chemotherapy, because it seems like the patients that are not having postoperative complications or anything like that. When it comes to determining your lymph node ratio, though, the important question is what was the difference and how many of them were positive, or how many lymph nodes were overall collected, and the standardization of the collection that was done for those lymph nodes.
Okay, thank you so much for your questions. So with regards to the first question, I think that was the chemotherapy regimens among the different institutions. That was actually one of our concerns, and that was why we only selected patients that received either modified FOLFIRINOX or Gemabraxane, and we kind of unified the cycles that these patients were receiving among the institutions. So we counted for that in our calculations and the statistical analysis. With regards to the second question, I think that was the radiation. So patients received neoadjuvant radiation before their surgery and with the chemotherapy, and we did count that in our univariate analysis, and we didn't see any difference between the two groups that either received the adjuvant chemotherapy or didn't with regards to the radiation that they received before surgery. And the other question, sorry. Oh, yes. Correct. So I don't have the exact number on top of my head, but we did look at that, and also we compared the total number of lymph node collected to see if there is any difference between the two cohorts, and we didn't see any difference. Again, we counted all those variables in our univariate to see if there was any difference, any significance, so we can include that in the multivariable analysis at the end.
So I've had plenty of patients where we started off on FOLFIRINOX, and then whether they've done well after the surgery or not, they, if they're not breathing, they should be, or they lost a lot of weight or something, we'll switch to that or something else. The same chemotherapy, both neoadjuvant and adjuvant for those patients.
So yes, that's an excellent question. And we also looked at that. So with regards to the matching between the neoadjuvant and their adjuvant chemotherapy regimens, we saw that the majority of patients who received modified FOLFIRINOX as the neoadjuvant, they received the same regimen as the adjuvant, but that was a slightly different with the other group that received Gemabraxane, and that was like significantly different between the two groups. But yes, we looked at that.
Okay, any other questions from the audience?
I have one. I mean, I would have many, but there's no time. About the chemotherapy duration, I know it's difficult to extract this information from a retrospective database, but why 3 months? I mean, it might be because the patient had toxicity, so you had to stop, and the planned chemotherapy was up for 6 months, like a total neoadjuvant approach, or you go by intention for a perioperative scheme like 3+3. This could influence the result because, I mean, if I plan a perioperative scheme, the histological examination is pointless because according to guidelines, I should go for 6 months regardless of treatment sequencing.
Correct.
Okay, so I go 3, operation, and 3, regardless of any histologic parameter. So why don't you run the analysis accounting just for patients who received at least, I wouldn't say 6 months because it's pretty unlikely, but at least 8 cycles of FOLFIRINOX, 4 months, to see if give additional chemotherapy matters and in what subset of patients.
Right. We actually, with regards to the cycles and duration, we mostly look at the cycles because that was kind of unified between the centers. So some of the, for example, we kind of converted the duration to cycles, so it would be unified between the centers. But again, we actually did look at those that received 6 months versus like different duration, but we didn't have enough patients, so the analysis was not really that significant.
Yeah, I know it's problematic when you deal with this database.
Correct.
But, 3 cycles of Gemabraxane is 3 months of chemotherapy. 3 cycles of FOLFIRINOX is 1.5 months. So it's pretty different.
No, I understand.
Actually, Dr. Malio, I'd like to comment on the comment that you made. We as a field, we do that, right? We overtreat patients. I think what Dr. Parekh was mentioning. We overtreat patients because we believe it works. I think the provocative part of this and the reason we wanted to look at this is that even if patients get 3 months of chemotherapy, we have those patients that are node negative. that are margin negative, and we perhaps overtreat in the adjuvant setting. And so the point of this was to say, listen, no matter what you got in the neoadjuvant setting, if your lymph node metrics are X, Y, and Z, if your pathologic regression rates are X, Y, and Z, are we overtreating patients? Because there is still, as you know, from SPAC4 and other trials, there is a subset of patients that just need surgery alone.
Yeah.
We just don't know how to identify them.
Yeah.
And perhaps this is a way of nuancing our selection of adjuvant therapy, because not all patients need to be treated. We overtreat a vast majority of patients to receive a benefit from chemotherapy in a small minority. I just want to put that out there.
Yeah, makes sense. Yeah.
All right, thank you.
All right. So last one from the MGH, Dr. Maximiliano Servin Rojas. It's Spanish is closer to my language, so I'm more likely to be correct. But you know, overseas I'm Giuseppe Mallio, something like this. So I'm supportive. Yeah. Okay. Serum CA1999 high risk of high-grade dysplasia in basic cancer in IPMN of the pancreas.
Thank you for the presentation, and the pronunciation was extremely correct. Thank you. I'm a research fellow at Mass General, and I'm extremely happy to present. I want to thank the HPVA for allowing us to present our work. We have no conflicts of interest to disclose. And as we know, pancreatic IPMNs are premalignant pancreatic tumors with unknown behavior, and while most of them are going to stay as benign lesions, some of them are going to progress to invasive cancer. So therefore, it's extremely important to be able to recognize these patients who benefit from surgery. Recently, serum CA99 was included as a worrisome feature in the 2017 revisions of the Fukuoka guidelines. However, this recommendation contrasts with most of the available evidence, where serum CA99 is a consistent predictor of malignancy. And even in the most robust prediction tools, such as nomograms, serum CA99 is included in most of them. Even some previous data from our own group have demonstrated that patients with invasive carcinoma have higher levels of serum CA99 compared with patients with either low-grade or high-grade dysplasia. And as we can see on the left on the table, rising levels of CA99 have rising levels of specificity. And this is not shown here, but it also has higher levels of positive predictive value. Therefore, we aim to compare the independent predictive value of serum CA99 with other worrisome and high-risk features to better delineate and understand the importance of CA99. We used a retrospective database, the MGH pancreatic cyst database, that spans over 3 decades. And the inclusion criteria were having a main duct, branch duct, or a mixed duct IPMN in the final pathologic analysis. The 2 main outcomes that we were interested in were the presence of either high-grade dysplasia or invasive carcinoma in the final pathological analysis, and these were analyzed separately. For the cutoff points of the different variables, we utilized the revisions of the Fukuoka guidelines. And for serum CA99, we added another cutoff point, which was based on our previous study that had the highest point with the highest specificity and the highest positive predictive value, which was above 100 units per milliliter. For univariable analysis, we used Cruxell-Wallis test, chi-square, and Fisher-Exact test as appropriate. And for the multivariable analysis, we used multivariable logistic regression model. We identified a total of 645 patients who met the inclusion criteria. 317 had low-grade dysplasia, 147 had high-grade dysplasia, and 181 had invasive carcinoma. And as we can see here, patients with invasive carcinoma were more likely to be older. We did not find any differences by sex. And we found that patients with main duct IPMN were more likely to harbor high-grade dysplasia or invasive carcinoma compared with patients with branch duct IPMNs. Mixed duct IPMNs had a similar behavior to main duct IPMNs. In terms of the worrisome and high-risk features, we found that patients with acute pancreatitis were more likely to harbor high-grade dysplasia compared to the other groups. We did not find any differences by cyst site, and we found that lymphadenopathy was more likely to be present in patients with high-grade dysplasia and invasive carcinoma. We found a similar finding for thick enhancing cyst walls. We found no differences for cyst growth over 5 millimeters over 2 years. And similar to lymphadenopathy and thick enhancing cyst walls, change in duct diameter and distal pancreatic atrophy was also more likely to be present in patients with high-grade dysplasia and invasive carcinoma. And in this slide, we have the most regarded like the best predictors for high-grade dysplasia and invasive carcinoma, starting for main pancreatic duct. As we can see, patients with ducts with 5 to 9 millimeters have also higher proportions in the high-grade dysplasia and invasive carcinoma group. And patients with ducts of over 10 millimeters have a lower proportion of patients with low-grade dysplasia and higher proportion of patients with high-grade dysplasia and invasive carcinoma. And this was very similar for mural nodules, where patients that have mural nodules over 5 millimeters were more likely to be present in the patients with malignancy. In the case of jaundice, we saw a similar finding with patients mostly presenting with invasive carcinoma. As we can see, there were not much of a differences between low-grade dysplasia and invasive carcinoma. In terms of serum CA19-9, we also find that patients with rising levels are more likely to harbor invasive carcinoma. And as we can see, levels over 100 have a similar behavior to pretty much all the other high-risk stigmata. And now when looking at predictors of high-grade dysplasia, we can see here that acute pancreatitis, lymphadenopathy, main pancreatic duct size, and mural nodule were predictors of high-grade dysplasia. And for this particular group of patients, serum CA19-9 was not a significant predictor for high-grade dysplasia. But when looking at prediction of invasive carcinoma, we can see that main pancreatic duct, mural nodule, and jaundice and serum CA19-9 were significant predictors of invasive carcinoma. And something I want to point out is that levels above 100 were actually the strongest predictor of invasive carcinoma in our sample of patients. However, our study must be interpreted with its limitations. It's retrospective. It's single center. This study only includes patients with resected IPMN, so it might be susceptible to selection bias. In conclusion, we found that serum CA19-9 was a poor predictor of high-grade dysplasia alone, but serum CA19-9, especially levels above 100, were the strongest predictor of invasive carcinoma in our sample of patients. The implications for our studies that we believe that serum CA19-9 above 100 should be considered a high-risk stigmata rather than a worrisome feature. Thank you, and I'm happy to take any questions.
Invite Dr. Noah Cohen from Mount Sinai for comment.
Congratulations on a very well presented study, adding really important information about CA19-9 for IPMNs, and thank you for sending me the slides ahead of time to review. I have a couple questions here. So you show that an elevated CA19-9 above 100 is the highest predictor for invasive cancer, but are you able to comment on how many patients had just an isolated CA19-9 as the only risk factor and didn't have any of the other risk factors that would otherwise prompt an operation or an endoscopic ultrasound with biopsy? That's my first question. Second question, how many of these patients went straight to an operation based on these risk factors and did not have a preoperative endoscopic ultrasound that would have identified a cancer? How often was a cancer not identified on an endoscopic ultrasound for those who did preoperatively, but then had a final pathology showing a cancer, and just the CA19-9 may have been the only high-risk feature to help predict that? Why don't we start with those? I've got a couple more though.
Okay, okay, that works. For the first question, I think it's definitely a very interesting observation. We did not look at how many patients had just exclusively invasive carcinoma. But then again, we ended up adjusting for pretty much all the other worrisome and high-risk features in the multivariable analysis, and this pretty much suggested this is an independent predictor, even when there's other features present or there's no other feature present. In terms of the second question, I agree. Endoscopic ultrasound is an extremely important tool for stratifying these patients. The rate of patients undergoing the endoscopic ultrasound in our the sample of patients was around 80%, because in a proportion of patients that have multiple worrisome features or high-risk stigmata, they proceed straight into surgery. And for the last question, there were 50 patients that had invasive carcinoma that did not have any significant finding in endoscopic ultrasound. And this 50 patients is just above 37 units per milliliter.
It's not above 100 then. You're saying
It's just including above 37.
Okay. So then other questions are, how do you, how would you incorporate this? Because as of right now, just an elevated C99 should lead to an endoscopic ultrasound, at least according to guidelines, right? So would you suggest that if you have an elevated CA99, maybe above 100, you would just proceed maybe right to an operation at that point? Like, how would you counsel a patient? And then how would you include this with cyst fluid analysis, like next generation sequencing, pancreas-seq as well? How do you think it's going to be incorporated in the future? Because you want to use this now as a high-risk stigmata.
Thank you for the great questions. For the first question, I would say that first, probably levels above, 37 to 100 should probably still be considered a worrisome feature, because as we saw, it was not a true strong predictor for invasive carcinoma. So I would say these patients definitely need an endoscopic ultrasound. And for levels above 100, we consider that this should be considered an invasive, high-risk stigmata, because there is a very strong prediction of invasive carcinoma. And I think these patients could be, this has to be confirmed in further studies, but from this study, we could conclude that these patients could be good candidates for a straight upfront resection. And am I missing another question?
Just how you think it'll be incorporated with like pancreas-seq or other methodologies.
Actually, there was yesterday a good talk about pancreas-seq, and I think that's definitely the next generation. It definitely has a higher specificity and sensitivity than serum C99, but the problem is that it's not widely available everywhere. So I think this still has probably a good promise as a serum marker that's probably cheap and inexpensive and accessible for most patients.
Thank you.
Thank you. I have a comment on the comment and a quick question. This is important, because when you find an elevated CA1999 in isolation, you don't know what to do. I would also suggest to repeat it in a short time frame, because a lot of times, very often, when CA1999 is elevated in isolation, you see a kind of waxing and waning pattern, which is innocuous, and it kind of stays over a long time period without any other worrisome features, high-risk stigmata developing. So might be something related to obstruction or to I don't know what, but it just can stay. Of course, you do ultrasound to see whether there is something you are missing. And the question, did you stratify the results based on the type of cancer, like colloid carcinoma or tubular carcinoma? And are you sure that all these carcinomas were actually arising in the background of IPMN, or they were like metachronous carcinomas? Because the role of CA99 could vary, could change according to the type of cancer. I wonder whether it's stronger in tubular carcinoma and weaker in colloid carcinoma. The two types of cancer are pretty different in terms of nature.
Thank you for the great question. We did not stratify by the type of histology. We did make sure that all of these patients were IPMN, invasive carcinoma arising in the IPMN. But I think we definitely have to look into the type of histology according to levels of CA99.
Thank you. Okay, thank you very much for this beautiful, exciting session. And
Thank you.
Thank you all. That's it.
Have a safe trip back home.
All right.
Very nice.
Nice work. Yeah. Yep. Sure, no problem.
I missed you.
Next time. Thank you.